For centuries, a teaspoon of table salt could mean the difference between life and death on the battlefield. Surgeons poured or packed coarse salt directly into infected wounds because it did something simple and predictable. It pulled fluid out, stung bacteria, and created an environment where germs struggled to survive. Without antibiotics, that physical effect, called osmotic drying, was one of the few tools doctors had to slow infection and stop spreading. Practitioners would sprinkle or cram salt into a cavity, press it gently into tissue, or soak dressings in brine. Then cover the area to let the salt draw out pus and reduce swelling. Patients remember a sharp, burning sting when the salt hit exposed tissue, often followed by a heavy, damp feeling easing into dryness and a slower return of fever. Painful in the moment, but sometimes the first sign of recovery. Stay with me to see the straightforward medical logic behind this kitchen remedy, how it actually worked in practice, and why people chose that sting over the alternatives when antibiotics didn't exist. Why doctors use salt for infection. Physicians reached for salt because its effects fit a simple, observable medical logic. Concentrated salt draws water out of living cells and surfaces, and microbes need moisture to thrive. When coarse sodium chloride was applied to a contaminated wound, it created a hypertonic environment at the surface, pulling fluid away from bacteria and softening the environment they depended on. In practical terms, this meant fewer active bacteria at the wound edge, slower tissue breakdown, and less foul odor from putrefaction. Those outcomes were tangible even when the underlying microbiology was not yet understood. Application methods were straightforward and varied with circumstance. Surgeons sometimes poured handfuls of coarse salt directly onto an open wound or packed a cavity with salt crystals to desiccate pus and reduce swelling. Other practitioners dissolved salt in boiled water to produce a rinse, using saline irrigations to flush away debris without adding new contaminants. Bandages were occasionally sprinkled with salt or soaked in strong brine before being applied, so the dressing itself continued to exert a drying, antimicrobial effect. Each technique reflected the same principle: reduce moisture, reduce microbial activity, and help the body form a protective scab or dry surface. Without antibiotics, these physical strategies were among the few tools available to slow infection and buy time for the patient's own immune response. Modern viewers can appreciate the logic. When you cannot kill bacteria systemically, change the local environment so bacteria cannot multiply easily. Salt was cheap, widely available, and required no special training to use, which made it a default remedy in battlefields, rural clinics, and ships' infirmaries where nothing stronger existed. Today we use isotonic saline to clean wounds because it does not harm living cells. Historically, people used much stronger concentrations because the aim was active drying and microbial suppression rather than gentle flushing. Patients' reactions were immediate and memorable. A poured or pressed on salt could sting sharply. People flinched, known to gasp or cry out from the sudden burning. Relief sometimes followed within hours as swelling lessened and offensive smells faded. Pain could decrease as pressure from swelling dropped and purulent material came to a dry surface that the body could more easily wall off. Those mixed sensations, acute discomfort first, then a gradual easing, made salt a visceral remedy people trusted, even if it was harsh. Understanding why salt worked helps explain why it persisted. It altered the local chemistry in a predictable, physical way. Salt's osmotic action, its ionic disruption of fragile microbial membranes, and the mechanical drying effect under bandages combined to reduce the speed of infection. The remedy had limits. Deep-seated infections and systemic sepsis could not be cured by salt alone. Still, in the absence of antibiotics, the practice of pouring or packing salt into wounds was a logical, observable intervention that could reduce local bacterial load, slow disease progression, and sometimes change a dire outcome into a survivable one. How salt was applied to wounds. When physicians and lay healers faced infected wounds without access to antibiotics, they turned to a simple mineral, salt, for its drying and antimicrobial properties. Salt creates a hypertonic environment at the wound surface, drawing fluid out of both bacteria and swollen tissue by osmosis, and thereby reducing the moist conditions that many microbes need to thrive. This basic physical effect is easy to explain to a modern viewer. remove the dampness, and you remove much of the shelter bacteria rely on. The absence of chemical antibiotics made these physical tactics the frontline option. Application methods varied with setting and available materials. Surgeons on ships or in field clinics often began by flushing a wound with clean brine or seawater to loosen visible dirt and reduce surface contamination. Simple irrigation was followed, when possible, by gentler rinses with clean water. In other cases, a practitioner would sprinkle coarse salt directly into the wound cavity or pack a wound with cloth saturated in concentrated salt solution, especially when they wanted persistent drying action between dressing changes. Dressings were then folded over the salt and secured, allowing the mineral to work while protecting the area from outside contamination. The practical steps were straightforward and driven by necessity. First, the wound was exposed and any obvious foreign material gently removed. Then salt was applied either as a grainy layer or as a strong saline-soaked dressing. Finally, the area was covered and observed, with dressings changed frequently to prevent resoiling. Painful though it could be, this routine aimed to reduce smell, drainage, and swelling, visible signs of improvement in a time when few other options existed. Some practitioners balanced the intensity of the salt by diluting it for irrigation, but using stronger concentrations for packing deeper, infected cavities. Patients' reactions were immediate and telling. A sharp sting or burning often accompanied the first contact, and many patients flinched or gritted their teeth during application. Short-term discomfort was commonly reported as a trade-off for later relief. Within days, swelling might lessen and the discharge become less fetid, prompting cautious optimism from both patient and caregiver. At the same time, excessive salting could harm healthy tissue and cause prolonged soreness, which is why modern wound care favors isotonic saline irrigations and avoids direct application of coarse salt. The historical practice survives in memory as a crude but understandable response to infection when no antibiotics were available. Did salt actually stop infection? Salt works in two straightforward ways that matter for wounds: by creating a hypertonic environment and by physically absorbing contaminated fluid. When concentrated sodium chloride contacts living tissue, it draws water out of nearby cells and into the salty medium through osmosis, which dehydrates many bacteria and inhibits their ability to divide. At the same time, coarse salt can pull pus and exudate out of a wound and dry the surface, reducing the nutrient-rich environment microbes need to thrive. Surgeons and lay carers applied salt in several practical ways. Sometimes they poured dry salt directly into a fresh or infected wound and then packed it with cloth or gauze. Other times they dissolved salt in water to irrigate and flush debris from a wound, using a simple cup or syringe to wash the area repeatedly. Poultices and compresses were also common, with salt mixed into dressings to keep the bandage dry and to draw out fluid. The technique was chosen for its availability and obvious immediate effect on smell and visible drainage. For patients, the experience was vivid. The first contact often caused a sharp sting. It burned. Many reported an initial increase in pain for a short time, followed by a feeling of tightened swelling as excess fluid was drawn out and the wound surface began to crust. Some people felt relief when the foul odor faded and less pus was apparent. Others suffered prolonged irritation because concentrated salt can also damage healthy tissue and slow repair when overused. The human cost was a trade-off: temporary pain for a chance to control a spreading wound with the tools at hand. In the era before modern antibiotics, salt was a pragmatic weapon rather than a cure-all. It could reduce surface bacterial numbers, slow the spread of infection locally, and make wounds more manageable, especially where no other antiseptics or sterile supplies were available. But it could not reliably eliminate deep-seated infection or stop systemic illness once bacteria entered the bloodstream. Today, we recognize that isotonic saline rinses are preferred for gentle cleaning, and that hypertonic approaches can be useful in specific wound care products. However, systemic antibiotics and sterile surgical techniques are necessary to treat many infections that salt alone could not. The historical use of salt therefore reflects both sound, simple hygiene and the real limits of what was possible before antibiotics and modern antisepsis. In short, salt was poured into infected wounds because its simple chemistry, drawing water out of tissue and microbes through osmosis, dehydrating bacteria, reducing swelling, and helping to flush debris, made the wound a far less hospitable place for infection. Doctors historically applied it in a few straightforward ways: sprinkling crystal salt directly into the wound, packing wounds with salted cloths, or rinsing with saline solutions when available. There were no antibiotics to target bacteria from the inside, so clinicians used what they could on the outside, accepting pain and variable results. Imagine a patient hearing the diagnosis, bracing as a nurse tipped salt into the sore. The sting brings tears and a moment of fear, then a tightness as swelling eases and the smell of cleansing shifts toward relief. It wasn't perfect, and sometimes it failed, but in many cases it bought time and reduced danger in an age with few options. If this surprised you, hit like and subscribe. We'll soon explore how antiseptics and antibiotics transformed wound care and what old remedies still teach us today. Share a remedy you'd like us to investigate next in the comments. Your curiosity drives the next story.